as an acute care case management director, manager, et cetera, has been really focused on readmission. That's right when I jumped into being a case management director in the acute care side was when readmissions first got popped into our brains. And I've made it a career and a study of it. My master's thesis was based on it. My doctoral thesis was based on it. My doctoral project was based on it. There's a lot of stuff I've been doing around it. My health literacy work is focused on using health literacy to readmission or to reduce readmissions as well. So I said, hey, you know what? Why do people have to go out and read all these articles to get up to speed on it? So I brought all that information together in one place, got you all the history of it, the whole 9 yards. And then I'm looking at the seminal work that was done in it, like Project Red and the Naylor model and transitional care management models, but then also looking at what's going on these days, where pharmacy has become very, very involved in helping reduce readmissions and the use of post-acute services and, making sure patients have the right care at the right place at the right time. And then again, the power of patient engagement and patient activation, because at the end of the day, who's the best person that can help us avoid readmissions? And that's our patients. So this book will be coming out literally by the end of this month. So watch my social media, because again, I love social media, for announcements, and it'll be available on Amazon as well. And thank you for the opportunity to promote that. All right, so I am a licensed continuing education sponsor for the state of Illinois for social work and for nursing. And this doesn't apply to you because Maureen's handling the rest of that. Disclaimers and disclosures: there are no potential conflicts of interest in the information in this presentation. All the material is either the opinion of the presenter, me, or cited to source or authority. Any products that I might refer to during this presentation are just for example. I am not recommending nor endorsing anything except for Coca-Cola. And I really wish that Coca-Cola would endorse me. So, a couple of things that we're going to be talking about this morning, and I'm going to move this over here, and maybe I will even go off video right now so I'm not a distraction. All right, ready? We're going to do a brief overview of the importance of improving our healthcare outcomes and patient experiences, because if we improve those, then our readmissions go down. We're going to introduce 3 key concepts: patient engagement, patient activation, which I already said are similar but a little bit different, and the concept of readmission reduction and why it's important. I know we all probably know, but it never hurts to refresh that. Then we're going to highlight the interconnectedness of these concepts in achieving better healthcare results. And we'll do that with some case study reviews. All right, make this happen, guys. Make this happen. Yay. All right. So differentiate between patient engagement and patient activation, identify some strategies to promote patient engagement and patient activation, and discuss that role in readmission reduction. We know that outcomes are everything, right? Part of the case management process is evaluation. And when we're doing evaluation, we're looking at patient outcomes. So it's not just how we get there, it's what happens when we do our thing. Patient engagement strategies are, of course, their approaches, their techniques, they're the way that we do things, the interventions that we do as healthcare providers and overarchingly as healthcare organizations to get our patients to be more involved in their own care. And by doing that, we also enhance their overall experience with the healthcare system. So an engaged patient is more likely to go to the doctor. The engaged patient is more likely to take their medication and follow through on that medication adherence. An engaged patient is more likely to have good open conversations with their providers and not hide things. An engaged patient, if they're having some bad side effects of a medication, will go to their provider and have a conversation about it rather than just go, oh, I'm not taking this anymore and throwing it in a drawer. All right. Patient engagement has become the cornerstone of modern healthcare for a lot of reasons. One, we talked about it, improved health outcomes, more likely to adhere to our treatment plans, to adopt healthy behaviors, to become that active partner in their healthcare condition management. And this, of course, leads to better health outcomes, reduced hospitalizations, which then reduces readmissions. But it also helps with our enhanced patient experience. We want our patients to be partners in healthcare. We don't want that whole old Marcus Welby, oh, the doctor said I need to do this. We want our patient to be part of that care team. And when we do that, when we make them feel like their input's valued and we empower them to be involved in their healthcare, we're talking about their overall experience improving. And again, this is fostering trust. It's reducing anxiety. We have much better patient and provider relationships. And guess what? We have reduced readmissions, we have healthier patients, and we have better patient experience scores, which we all live and die by, right? We have cost savings. Engaged patients are more likely to be engaged in their healthcare, right? So if they're doing that, they're more likely to seek that preventative care. They're more likely to be at the physician's office more often, seeking early interventions rather than using the emergency room as the primary care physician, therefore ending up in the hospital more and more often. We also want a more efficient healthcare system. I know this past 2 weeks, my hospital has been running at 98 to 102% census. And that's because our ED is being used as a PCP's office, right? We've got a lot of people coming in. They're coming in sicker because they're waiting longer before they get involved in the healthcare system. Oh, maybe this will go away. Oh, I just don't want to go to the doctor. Maybe they don't have a doctor. Maybe they don't have insurance. And so therefore they're not going to their physician. So they're utilizing the emergency room only when it gets to be so bad that they can't manage it anymore. So patient engagement really does lead to more effective utilization of our healthcare resources. And, again, when patients are actively participating in the care and their care decisions, we as healthcare providers can allocate the resources more efficiently. We're not, having to build bigger emergency rooms. We can build bigger clinics and primary care practices instead. And then, it really gives the opportunity to tailor the treatments to their individual needs, giving them more time with, the provider. ED doctors don't have the time to sit down and address all the social determinants of health, where a primary care provider has a little bit more time where they can have those conversations and do a better screening and a better assessment to figure out what exactly is the root cause of these issues. So for our patients, patient engagement leads to a greater understanding of their healthcare condition and their treatment options. It increases their motivation to make healthier lifestyle choices. It improves the adherence to their medications and their treatment plans, and it enhances their quality of life and their overall well-being. For healthcare providers, I don't know about you, but I prefer a more informed, more empowered patient because this leads to better outcomes. The collaborative decision-making that occurs when you've got a patient who considers themselves to be part of that care team rather than the person that all this stuff is happening to is much better, because we're now including the patient's preferences and the patient's perspective into this because we know about it. Of course, we've got increased patient satisfaction and loyalty. They're going to come in and they've got the trust in the healthcare system, and then reduced healthcare costs because they're accessing preventive care and self-management skills versus emergency care and hospitalization. For a healthcare system, lower rates of readmissions, that's always a good thing, right? We get dinged for that up one side and down the other. And emergency room visits. Emergency rooms are at the capacity. We want to make sure that we can serve everybody in an urgent nature. We can have better allocation of resources based on our patients' needs and preferences. Wow, wouldn't that be great to have all that data in one place to say, we have a food desert in this section of town, how can we fix it? And then work with, grocery stores or food pantries to create a solution in that area. And then long-term savings, cost savings as a result of course, improved patient care, fewer complications, better quality of life. So here's Maria. Maria's been diagnosed with type 2 diabetes. In the past, she's felt very overwhelmed by medical jargon, which you should never use when you're talking to your patient, and has struggled to maintain a healthy lifestyle. However, with a new focus on patient engagement at her healthcare facility, her experience has begun to change. So, from the patient's perspective, Maria is attending a series of educational sessions that are provided by her healthcare team that helps her to understand her condition. And she now understands the importance of managing her blood sugar levels rather than letting her blood sugar levels happen to her. This leads to a greater understanding of her health condition and the treatment options available to her. She's motivated by her newfound knowledge, wouldn't you be? And she starts making those small, sustainable changes to her diet and exercise routines. And she's demonstrating an increased motivation to make healthier lifestyle choices. Additionally, she's now found that she's got an app available to her on the phone to remind her to take her medications, which is helping her to improve adherence to her medication and her treatment plans. And so, with these very small changes, she's noticing that she's got more energy, that her symptoms are reducing, she's got a better quality of life, and she feels better overall. Wow, how awesome is that? 3 small things that she's done. Maria's healthcare team is monitoring her progress through the app because it reports back and forth to her. And of course, she's going to her regular checkups more often. They find that she is more informed and she feels more empowered. And of course, this is leading to better outcomes. When considering a new medication, Maria's doctor is now discussing the options with her, taking into account her preferences, her concerns. This is collaborative decision making. Maria feels more satisfied with her care, more loyal to her healthcare providers because she's been an active participant in her treatment. They've been active participants in her treatment. She's more satisfied and she's going to stick with these docs because they take care of her. Her proactive approach to managing her diabetes, of course, means fewer complications, reducing healthcare costs because she's going to the provider's practice for preventative care and better self-management skills. And then the healthcare system, well, hey, more patients like Maria continue to engage in their health management. The system sees lower rates of hospital readmissions, lower use of the emergency room visits for primary care use. The resources are better allocated. More emphasis is put in the outpatient area rather than having to staff that emergency room or put in more beds in the ER. And then with patients managing their conditions more effectively from home, the system benefits from long-term cost savings as a result of course, improved patient health, but fewer complications as well. So you can see now the impact of patient engagement. It does have a domino effect. It's not just benefiting the patient, but the entirety of the healthcare system and the healthcare providers. As the patient becomes more knowledgeable and more empowered, they make better health decisions. They're more engaged, they're more open, they have good conversations, they're more educated about what's going on. And this cannot lead to anything better than more improved health outcomes and more efficient use of healthcare resources. Throw your questions in the Q&A as we go. I will answer them at the end. Sound like fun. All right. So some strategies for promoting good patient engagement. One, the very, very first and biggest one is shared decision making. We cannot be Marcus Welby-esque 1950s healthcare. Our patients deserve to know what's going on with them. Our patients deserve to be involved in the care discussions. They should know about the treatment options. Informed consent is exactly that. Informed consent. They should know the risks, the benefits, the alternatives. And informed consent should be part and parcel of what we do on a daily basis, not just when we're trying to get something signed for a surgery. What's going on with that medication? How is that going to make me feel? You know, what are the side effects of it? And are there any alternatives for it? We need to respect our patients' preferences and values when making decisions. Some people have cultural or religious reasons for not wanting to participate in certain treatment options. They understand the risks and the benefits. We have to respect that. But it doesn't necessarily always have to be a cultural or a religious issue. It could just be, you know what, that's not how I want to live my life. That's not going to contribute to the quality of my life. And this is what quality of life looks like to me. So we have to respect our patients' preferences, their values, what they want their life to look like when we're helping them make treatment decisions. We should encourage them to ask questions and express their concerns throughout our interactions with them every time we see them. So shared decision making, as you can tell, I'm a huge promoter of shared decision making. Open communication. We need to create a welcoming and non-judgmental environment where our patients feel comfortable in confiding with us, sharing their thoughts, sharing their concerns, letting us know what's going on. I mean, I'm probably the worst patient in the world. And it took, I've been having these allergic reactions for the past month. My eyes are red and they're swollen, but it took until my eyes literally swelled shut last week for me to actually call my physician, because I was trying to do it all by myself. And I was just like, oh, you know what? I don't want to be bothered. I ended up having to go into his office, and my PCP has just recently retired, and I have not seen the new person that she assigned me to. So I texted one of my friends who's a nurse practitioner, and I'm like, hey, you know what? I need some help here. So he got me aligned with his practice partner. I went in to see his practice partner, who I've known for years. We used to work together at a hospital I used to work at, and he's looking at my face and he's like, oh my God, he said, from the pictures that were sent, I thought you had lupus. And that's like, no, I'm having an allergic reaction to something. I'm not quite sure what. So at the end of the visit, we're having a conversation. He's like, I don't want to put you on oral steroids because you've said, he first broached oral steroids. I said, you know what? Oral steroids make me crazy. Seriously, they do. I don't sleep. It's an awful thing. And he's like, okay, so instead of a attractive oral steroids, we're just going to give you a shot of Solumedrol. We'll see what happens with that there. I was on board with that because it wasn't going to like totally send me off my rocker for a week. Having those conversations where I was able to, and felt comfortable having conversation with him, okay, what's going on with this? What's going on with that? And it was an awkward conversation, I'll tell you that, because we've known each other on a social level and not on a medical level. So it took a little bit of time for me as the patient. Now, keep in mind, I wasn't there as Colleen nurse. I wasn't there as Colleen case manager. I was there as Colleen patient with her eyeballs, with her eyes swollen shut. Not a great time for me to be having a conversation, very stressful for me, but he made me feel comfortable. He made me feel welcome. He squished me into his schedule in an urgent fashion, and he's just, he's looking, he's like, okay, let's think about this. What's been going on? So we started backtracking and things like that. And we did finally figure out what I'm allergic to. The one shot of Solumedrol actually worked overnight to get this done. And so I only had one sleepless night. And he did actually listen to what I was saying. He addressed my questions. He addressed my concerns about the Solumedrol dose pack, and saying, okay, there is an alternative, one night of no sleep versus 7 nights of no sleep. And he explained it to me very, very clearly, even though he knew that I was a nurse for 9 million years. He used very plain language because he recognized that I was not in a spot or in a place to process medical jargon at that moment in space. And he treated me just like he would treat any other patient, avoiding that medical jargon and explaining things in a way that people could understand. So a lot of you probably have heard the story of my mom and her diagnosis with Parkinson's, where my sister and I drove out to Missouri to figure out what the heck was going on with my mom. She had lost 50 pounds in about a 4-month period of time and was getting to be very forgetful. And this was not a forgetful lady. She was an ICU nurse for 38 years. And when we got to Missouri, we made an appointment with her primary care physician, and having conversations at this appointment. And we uncovered the fact that my mom had stopped taking a medication because she had misheard the physician, but they were still assuming that she was taking the medication because they had told her not to stop taking the medication and to stop taking another medication. And when I asked the physician about, the gap in the care and why this had happened, she said to me, she goes, well, your mom's a nurse. I thought she would just know what to do. When it doesn't matter what the person does for a living, what their educational preparation is, it doesn't matter where they come from or, who their friends are. It really matters that we treat each patient, as equal to, we're going to explain it to you in the easiest way to understand it, because one, they're in crisis probably when they're seeing us. Two, just because my mom was a nurse for 38 years didn't mean that she was able to process what was going on right then and there. And she could not process it. 2 weeks later, we had a diagnosis of stage 3 Parkinson's with dementia. So yes, she was not there anymore. But they were assuming that she was going to be able to manage this because Patty's a nurse. Doesn't matter. Use clear explanations, plain language, that language that we all learned to go to nursing school, to go to PT school, to go to social work school, to go to medical school. Forget it. That's for charting. When we're talking to people, we're talking to them like people. All right, soapbox. So promoting patient engagement through these strategies helps our patients benefit themselves, and it contributes to better, more effective, patient-centered healthcare delivery. And of course, what does that lead to? Healthcare outcomes, better healthcare outcomes. All right. 3, health education and information dissemination. There's some big words there. So basically, offer your patients the educational resources. Look back to that case study that we just looked at. Maria has been struggling to manage her diabetes. The primary practice says, hey, we've got these educational sessions we'd like you to come to. So we're offering that patient some educational resources that are not just here's a pamphlet, read it, but they're interactive or they're conversational or whatever way that the person best learns, to empower them to understand what their condition looks like and what the treatment plans are going forward. We can provide written materials. We can provide videos and visual aids. Remember, not everybody learns the same way. Okay. And before you start providing written materials to somebody, make sure that they can read it. It's got to be in their language that they can primarily read in, and it should be at a 3rd to 5th grade reading level. But let's go a little bit further. The literacy rate in the United States is very, very low. Okay. I've had patients that we've sent them home with about a 4.5-inch thick packet of paper about 4 or 5 times in a row. This guy was readmitted. This one guy, he sits on my shoulder every day. 4 or 5 times he was readmitted within about a 6-week period of time. We'd send him home with the same packet of information. We'd send him home with the micromedics for all of his medications. He was on 15 different medications. The micromedics for all 8 of his comorbidities. And then the standard discharge packet with all of his follow-up visits and blah, 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 and all that other stuff. Literally almost a ream of paper. Because we wanted to do a good job of educating our patients. But we're not educating our patients. We're throwing paper at them. Come to find out, after I called him on the 3rd time, because this was right around the time that I read June Stark's article about readmission reduction, and I went, "Ooh, this is cool. I got to get going on this." I called him and I said, can you tell me what's going on? Did you get the information? And blah, 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 blah. He was so confused by the vast amount of stuff that we'd sent home with him. And it was written in medical ease, not patient friendly, right? But then digging a little deeper, this gentleman had never even graduated 8th grade. He did not have an appropriate reading level to be able to read all those written materials. He was overwhelmed by them. He was embarrassed to say anything to anybody. And therefore, he kept coming back to the hospital, back to the hospital, back to the hospital, because he just wanted somebody to talk to him and get this fixed. But instead, we threw paper at him so we could check a box saying patient education given. Again, tailor your education to your individual learning styles, to that patient's preferences. You might have to dig a little bit to find out that, it took me several phone calls and a long time to find out that this patient actually could not read the information we were giving him. The use of patient portals and digital tools. And our case study, Maria now has access to an app that helps her to manage her blood sugar and gives her ideas. And that app talks to the primary care provider and they can see things in real time. Patient portals are great for granting patients access to their medical records, to our test results, to the treatment plans. offering those digital tools such as the mobile apps, remote monitoring. I remember when we first started working in readmissions, and every home healthcare agency that would come to visit me at the hospital, oh, we have remote monitoring. Okay, what does that mean? How does that work? And then it's like, oh, we have remote monitoring. Everybody had remote monitoring. Tell me what makes you different. But remote monitoring, again, remember back in the early days, remote monitoring was the patient inputting something into a site or something, and then that going to the primary care provider. It wasn't as sophisticated as it is now, where you've got the blood pressure cuff or the scale directly communicating to the primary care provider. So sometimes it could be falsified, right? But you have to take advantage of these types of digital opportunities that help our patients become more empowered. They can track their health metrics. They can get back personalized information as well. But remember at the same time, and this was covered in our new HIT standard of practice that came out in 2022, I believe. Yes, I think it did. Make sure, and this is one of the things, again, going back to health literacy and patient engagement, make sure that your patient or their caregiver are savvy enough to be able to manage that. You ask my dad to go on his patient portal. My dad is 80 years old and does not own his own computer. He will look at you and go, nope, I want to talk to somebody. Now, his 84-year-old girlfriend, she's got her iPad, she's got her cell phone, she's in and out of his portal, she's in and out of her portal. She's got everything going on. So make sure that's part of the HIT standard. Make sure that you're assessing your patient for their ability and their willingness to utilize patient portals and digital tools. Okay. All right. We can also offer, hold on, I got to move this out of my way because I used up the entire slide. Telehealth services. Oh, I love telehealth services. The VA is like the best at telehealth services. They are like the vanguard of telehealth. Offer virtual healthcare services for remote consultations, for follow-up visits, for healthcare guidance. The nurse practitioner I told you about a little bit ago, when he was finishing up his doctoral project was reducing readmissions by using telehealth services in a primary care practice setting. So he noticed that a lot of his patients would not come in for their follow-up visit after being discharged from the hospital. Well, I've done a little bit of work on that too. You know what the biggest thing that people say about I don't want to come back to the doctor is, I just saw a whole bunch of doctors in the hospital. Why do I need to see another one? It makes a little bit of sense, but not really. So he said to himself, and he was working with me, he's like, what do you think about using telehealth services to increase the attendance at the post-hospital visit? And I said, well, it's brilliant. Let's see if it works. So he did. We put a program together and we worked on it. And he had about a 97% attendance rate at the telehealth visit. He only had about 10% that he said, you know what, I really do need to see you in the office after this. So he was able to get them to come in because he'd made the first attempt to see them remotely. And his readmission rate from that pot of people dropped it to zero, because he was meeting people where they wanted to be met. Not a lot of people wanted to go out over the past 2 years, 3 years, right? So these remote consultations really did help. And making and the adherence to follow-up appointments. And then he was able to do a screening or a mini assessment and say, I do really need to see you. But that decreased the traffic in the office as well, which helped a lot, especially during COVID. And his patients saw him as being more available to them, so they had no problem chatting him or calling or leaving a message and saying, hey, I really need a little bit of assistance on this. I don't understand it. Can you call me back? And he would have no problem giving them a call back and to give them the guidance that they needed. Support groups are also really great. Facilitate support groups or online communities where similar condition patients can connect, where they or their caregivers can share experiences and offer emotional support. There is a link in here in your materials. It's called the Center for Chronic Illness.org, and they connect you with all different types of programs for support groups for a bunch of different chronic conditions. So, COPD, Parkinson's, they've got a listing of it all, and you can click right on them and get connected in your area. Feedback collection. Regularly gathering feedback from your patients about their experiences with the healthcare system. Well, yes, we see HCAPs all the time. But I really would like to hear in the patient's own words what's going on. So, when you're talking with your patients, how's everything going? Is there anything that we can improve on? Use that feedback that you're getting to improve those services, to fix the processes that are broken, and to improve your patients' interactions. Your HCAP scores only tell you that 85% of your people said X, Y, and Z, but they didn't tell you exactly what was wrong, or they didn't give you the kudos and say you should keep doing this. That's why that actual narrative feedback is very important. Health literacy initiatives. Oh my goodness. Again, I will sit here and talk to you about health literacy until I cannot talk any longer. You need to develop initiatives to improve the health literacy among your patients. Eliminate your medical jargon where you can. If you can't eliminate it, explain it. Explain their treatment options and explain their treatment instructions. Explain how important it is for preventative care. Use examples if you've got them. We all know people that did not go for their colonoscopy, with a family history of colon cancer, and bad things happened. We don't want to scare people, but at the same time, we can utilize those types of examples to be, this is why preventative care is very important. And click. Cultural competency. We need to make sure that our providers, our team members are culturally competent and sensitive to the people that they are working with. This is not a one size fits all kind of a thing. Make sure that you're very sensitive and understand your patients' diverse backgrounds, their beliefs, their needs, because each and every one of those things contributes to their healthcare experience and how they can or will manage or not manage their care. Gamification. Oh my goodness. I'm hoping I can click into this because this is one of my most favorite things in the entire world. Making healthcare engagement into a game is probably one of the most brilliant things I've ever seen. And it's been done incredibly well by UPMC. And I'm going to try to click on this here. We'll see if it works, okay? And if not, I might have to dive out for a hot second to get to it. I really want to show you this. So give me 5 seconds. And I'll see if I can get into it. Oh, maybe we'll do it at the end. That'll be fun. All right. UPMC worked in collaboration with a game developer and created a really cute little game called Heart Failure Coach. I know it sounds like, oh, that would be cute, but it is. It's really cute. Follows a patient for 7 days post-discharge from the hospital. And it's kind of like a choose your own adventure book. Every time Simon, that's his name, asks you a question, what should I do? You answer it, and you can go off onto this tangent, or you can go off onto this tangent. You can't really play the game the same way twice, which is great because it helps our patients understand healthy choices. Oh, should I weigh myself this morning? Nah, don't do that. It has consequences, right? So I'll demonstrate that at the end because it's really awesome. But there should be more of these for more chronic conditions so people can learn how to do it in a non-threatening environment. Wellness and preventative programs. Programs are available all over the place. I've seen hospital systems offering wellness programs, making sure that there's workshops available. I used to work at a hospital here in Chicago, and they actually had not just a kiosk at the mall. This is back in mall days, by the way, but they had an entire storefront at the mall that was all meeting rooms, and they had an education schedule, and they had senior exercise classes. It really very engaged in the community, and it was to promote preventive care and healthy lifestyle, and provide some socialization. It was an awesome little place. I used to go there a lot just for fun. And then follow up and reminders. send those reminders for the appointment. Maybe set them up with an app that reminds them about their medication schedules. Send them text messages saying, hey, you're due for your colonoscopy, so that they can stay on track with their care. So this is a circle, right? We do assessment, we engage them in their strategies, we do assessment, we re-engage them with strategies, making sure that these are based on their patient feedback and what's new, what can we play with? I mean, 20 years ago, we didn't have heart failure coach in a game on your phone. Now we do. What's going to come in the next 15 years? What's going to come in the next 5 years? And with AI, what's going to come in the next year? Think about that. But remember, at the end of the day, that your patient engagement strategies really need to be tailored to your patient's needs and preferences. If not the individual, then the patient population that you're serving. Okay. So now we're getting into our patient activation. Activation refers to the knowledge, the skills, the confidence, and the willingness of that patient to actively engage in their own healthcare. Okay. Patient activation is usually measured on a scale where individuals can progress from being those passive recipients of Marcus Welby type interventions to active participants in their health and wellness journey. The concept of patient activation is very closely related to patient engagement, but remember, this is focusing specifically on that single patient's ability to motivate and motivation to manage their healthcare effectively. Not on camera, so you're okay. All right. Higher levels of patient activation also better health outcomes, improved adherence to treatment plans, and reduced healthcare costs. All right, patient activation. We need to build knowledge. We said it's building knowledge, enhancing skills, boosting confidence, and fostering motivation. So how are we going to build knowledge? We know that patients that are more highly activated, they actually actively seek out information about their health conditions, their treatments, and their self-care strategies. They know that this knowledge enables them to make informed choices. So we got to get them to this point where they're actively seeking out that information and being involved in their healthcare. They have to have skills that are available to them or that they've developed to manage their medications, to monitor their health metrics, to recognize the signs of a potential health issue. It's more than a stoplight report that they put on their fridge and cover with magnets, right? They need to know how to take their medication, when to take their medication. There's a really great video put out by the American Medical Association on health literacy, of course. But one clip in there is this patient, and she's got this big box of medications. And they ask her, how do you take your meds? And she says, I take 16 medications a day. And nobody's ever sat down with me and told me, I have to take this one twice a day, but they don't tell me what time to take them. So she's like, I don't know if I take this one in the morning, in the evening, in the morning, in the afternoon, or the afternoon in the evening. So you know what she said? Oh my goodness. And when you watch it, you just go cringe. She goes, I take them all in the morning, so I know I have them. That's not good managing medication skills, right? Monitoring health metrics, with the onset of more digital remote monitoring, we can hook patients and tell patients to take their blood pressure. It does it automatically, but back in the day, we were asking people to input their numbers. And just like, anything else, when you're doing things based on manual input, it could be garbage in, garbage out. And you don't know that somebody's blood pressure is off the chain for 3 days in a row because they're reporting it as being normal because they just don't feel like doing it. Right. And then again, we've got great stoplight reports. They're paper. You put them on your refrigerator. You can look at them. 1, can the patient read? 2, are they using them? 3, is it covered over with magnets and other notes on their fridge? All right. We need to do a better job at enhancing their skills and actually giving them skills. Boosting their confidence. Dr. Eric Coleman did a great project with Dr. Wasserman on health confidence and the impact on readmissions. And basically it's looking at a patient, it's a single question. It's just a little tool. And it says, how confident are you that you can manage your healthcare needs on a scale of 0 to 10? Now you want to get to at least a minimum of 7. When I used it for my readmitted patients, our average score was about a 5.2. So we knew that we had some work to do. So we needed to get our patients to be more confident in managing their healthcare issues. That gives them control, that gives them a sense of empowerment. And when you give them control and empowerment, you're boosting their confidence because they feel that there's something that they can do about it, rather than just being a victim of this circumstance or condition. I often hear oh, well, this unfortunate patient, I read this in H&Ps all the time from older doctors, this unfortunate patient suffers from, it's like, okay, thanks for just taking all their confidence away. How about Mr. Smith has this condition that we're working on managing? Fostering motivation, higher activation levels, gives our patients the ability to set and achieve health goals. So, I want to manage my blood pressure within a normal range by doing X, Y, and Z, not just taking my meds, but maybe exercising more often. Maybe I'm going to stop smoking. Maybe I'm going to give up full sugar Coca-Cola instead and drink zero sugar Coca-Cola now, which was a huge healthier lifestyle change for me, let me tell you. And actively engaging in preventive care. So how do we assess our patient's activation? Well, why would we do that anyway? Oh, well, we're so busy. We hear that all the time. One, assessing this patient activation gives us the opportunity to customize that individual care to that individual patient, because not everybody is activated at the same level at the same time. So as a healthcare provider, you need to know where your patient is in that continuum. We can then target our resources and focus on the patients that need more additional education or support. And what types of education and support do they need? Do they need the basic to get them started to be activated? Or are these activated patients who need that little nudge to get to that next level? We know that patients with higher activation level are more likely to adhere to treatment plans. Of course, that leads to our better outcomes. And then we can also use this as a regular assessment that gives us the opportunity to track that patient's activation and how well the interventions that we're putting in place are working for them. All right, so stages of patient activation. 1, we have to believe that the patient role is important. Patients in this stage may lack their knowledge or their confidence to actively manage their health. They may just be still in that passive healthcare happens to me mode, and they might not be active participants in their care yet. Stage 2, building that knowledge and confidence. They may start seeking information about their conditions and treatments. They may become more aware of their healthcare needs and could start asking questions and participating more in discussions with their healthcare providers. Rather than, in the acute care setting, the resident team comes in the room. Oh, do you have any questions? Nope. And then when they leave, they've got a ton of questions for the nurse, and the nurse says, let me go get the physician team back. And then when the physician team comes back, they don't want to have a conversation. Stage 3, taking action. At this stage, people are actively making decisions about their care. They're setting goals. They're doing the follow through with the treatment plans. These people at this stage are more likely to adhere to medications, to recommendations for lifestyle changes, and making those lifestyle changes. And then at stage 4, you've got maintaining behaviors. Patients here have developed those sustainable habits for managing their health. They are less likely to be influenced by setbacks. And of course, they are more better equipped to handle any other changes in their health condition that might come down the road, because they'll be like, okay, wait, all right, we're going to go back a little bit. We're going to seek that knowledge. We're going to start understanding. We're going to start asking questions. They know what they need to do at that point, even if there is a setback, to say, okay, I have the skills to be able to figure this out. And I know who I need to go to get this information. Sorry for how small this one is. I don't know why it turned out like this. So we want to make sure when we're promoting patient activation that we're giving personalized information, personalized education, because again, every person is on a different level when it comes to patient activation. Make sure that the resources that we're offering our patients are specific to their health conditions and their concerns tailored to their individual learning preferences. So again, you may have somebody who doesn't like to read a whole bunch of pamphlets. You might like somebody who wants to watch a couple of YouTube videos. There's a ton of them out there. Figure out which ones are the best and put those in your toolbox. Goal setting and action planning. These are collaborative patients. They want to work together to set health goals. So they will say, okay, how do I get there? And it's our job to help them break that down into those easy to digest smaller goals and smaller steps to get to that bigger goal. Somebody comes to you and says, I want to lose 100 pounds in the next year. We're not going to go, okay, let's, we'll celebrate when you hit 100 pounds. It's going to be 5 pounds. It's going to be 10 pounds. It's going to be 20 pounds. And each stage, how are we going to get there? How are we going to get there? That keeps it in focus. Those smaller, manageable goals make the bigger goal achievable. Because sometimes that bigger goal looks like Mount Olympus. We're never going to make it there. Supportive communication. We foster an open dialogue where our patients, of course, can ask questions, where they can express concerns, and we are actively listening to what they have to say. We are actively incorporating their preferences into our treatment plans with them, not for them. And then positive reinforcement. Of course, we need to acknowledge and celebrate their progress and their accomplishments. So if your patient has a goal of losing 100 pounds and they've lost 20 pounds, let's have a party and yay, this is great. Woohoo. When I put together one of my first readmission reduction programs, we followed our patients actively for 30 days post-discharge. We literally micromanaged them through the first 30 days after they were discharged from the hospital. And on day 31, we'd call them and we would, congratulations, you've been out of the hospital for 30 whole days, blah, 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 blah. We sent them a certificate in the mail. We celebrated them. However they wanted to be celebrated, we celebrated them. And let me tell you that certificate in the mail with like a total cost of what, $1, was so well received because they felt that they had accomplished something. And that's awesome. Providing that positive feedback. Hey, you know what? Then they went for 45 days without being in the hospital. Then they went for 60 days without being in the hospital. It continues to build because they recognize that they are doing something positive for their health. All right. So busy slide. So patient engagement refers to the overall process of involving patients in their healthcare and encouraging their active participation in decision-making, care management, and health-related activities. Where patient activation is the specific patient level knowledge of skills, confidence, motivation that an individual has to manage their health effectively and actively participate in their care. So patient engagement is the process of involving our patients. Patient activation, like we've been discussing, so this is a summary slide of everything we've been discussing up to this point. Patient activation is a very individual thing, meeting that patient where they're at that time, focusing on their readiness, their ability to take responsibility, looking at their capacity to be able to manage their health and their confidence in doing so. Excuse me, I'm going to take a drink real quick. All right. So key similarities, they both emphasize the importance of involving patients in their care and the decision-making process. Both concepts aim to improve patient outcomes, to enhance patient satisfaction, and to contribute more effective use of healthcare resources. Patient engagement, of course, like we just said, broader concept that encompasses various strategies, while patient activation focuses on the individual and their readiness and ability to manage their health. Patient engagement creates supportive environments. Patient activation equips individual patients with necessary tools to participate effectively. Patient engagement emphasizes the collaborative relationship between patients and providers, where patient activation is really focused on that individual patient's personal growth and development in managing their healthcare. They're interconnected, they complement each other, but one is a process and a strategy, and the other is focused on the individual. And the bottom line, patient engagement strategies create an environment for patient activation to occur. When patient activation enhances patient patient's ability to engage effectively in their healthcare journey. So we need patient engagement strategies to create an environment for patient activation to actually happen. I'm pretty sure the majority of us are familiar with this, but it could also bear some repeating. Sometimes we have tools and we put them away in our toolbox and we forget that they're there. The patient activation measure, the PAM, is widely used. It was developed by Judith Hibbert and Helen Gilbert to assess individuals' level of patient activation. Again, measures knowledge, skills, confidence, motivation, right? And it looks at figuring out where that person falls on a continuum so that you, as the healthcare person, the case manager, the healthcare provider, can find your patient along that continuum and give them the individualized interactions and education wherever they're falling on that continuum to help them get to the next level. So we talked, it's the same stages that we were talking about earlier. So identifying where your patient is falling within this. So level 1, our patient is disengaged and overwhelmed. How many times have you gotten a patient that has gotten a new diagnosis of either a chronic condition or a life-limiting condition? People are overwhelmed. They're passive. They lack confidence. They don't know anything about this. They just got this news. They're probably in denial. When you ask them what their goals are, they just look at you and tell you to leave the room. And of course, their adherence is not going to be the best. These are the patients who, again, Marcus Welby, 1950s, the doctor is in charge of taking care of my health. Level 2, becoming aware, but still struggling. Okay, now they've learned a little bit about their condition, but they still have huge gaps. They believe that their health is largely out of control, but they see that they can set some simple goals. Like with my guy that was readmitted a couple of times in the month period of time. He knew that he had CHF. He understood a little bit about what it was about, and he could tell me that he needed to limit his fluid and his salt intake. But aside from that, he hated the Lasix, especially in the evening, because it kept him up all night. And he did not realize that, he was a single dude, didn't like to cook, so he would eat out a lot. And, McDonald's, Burger King, high levels of sodium. He didn't know what was in it because they didn't have food labels. He didn't realize that soup was a liquid. He didn't count it as a liquid because he used it for a meal. So all these things that we've got to do education, some of it rather basic, and you look at it and you're like, you don't know soup's a liquid, but he was not thinking about it as liquid because he had it for dinner. So therefore it was dinner. Liquid to him was water, soda, beer, whatever. Level 3, taking action and gaining control. Now they've got the key facts. Now they're starting to build that self-management skills. Now my gentleman realizes that he can't go to McDonald's all the time because that quarter pounder has got 1,200 milligrams of sodium in it, and that puts him over his sodium intake for the next 3 days. Now he understands that, and he's like, ooh, I got to start eating different food. And now we've got to identify food that he likes that's easy for him to make because he's not a good cook. But at the same time, how can he do this and still maintain his social life as well? My dad was a perfect example of that. My dad was a tanker driver for Shell Oil for 80 million years. And he would wake up at 3 o'clock in the morning and come home from work at like 4 o'clock in the afternoon. And by the time he got home, he was dead tired. He was a single dude at the time. So he would just buy himself a whole bunch of those prepackaged frozen dinners, throw one in the microwave, eat, and go to sleep. And then he wondered why his blood pressure was going up because there's like 600 milligrams of sodium in those things. So, once I started cooking for him and freezing meals for him, it got much better very quickly. And then he started learning how to cook for himself. Yay! All right. Level 4 then is maintaining those behaviors and pushing further. So, I showed him how to decrease his sodium, and then he started learning how to make some simple foods and things like that. And then he actually started getting really good at cooking. And now he loves to cook. It's very weird, but it's true. So how do you use that? Well, you tailor the interventions. That PAM score helps us look at the patients and say, okay, where are you at on this? What do you need? Basic information? Are you moving along? And do I have the opportunity to introduce newer topics and some better interventions, higher level interventions? It's going to help us to predict those outcomes, because we know that if our patients are not activated, if they're in that stage 1, we got a lot of work to do. And we're probably going to see that patient several times before we get them engaged and moving forward. It's going to help us to evaluate our programs as well. Realizing too that we can put the best program in the world together, but if our patient is not going to engage in the program, or they're not in the headspace at that point in time to really get involved and take that information in, we're just literally talking to the wall. And it might take a couple of times for them to actually start participating, and that's okay. I mean, you get a diagnosis like that, and the first thing that goes into your head, of course, is denial. Nope, not happening to me. I'm not going through that. That's not happening. It also helps us to personalize our care plans. Really, I mean, talk about patient-centered, personalized healthcare right there, right? You can take that information and you can move that patient along the care continuum at their speed, looking at topics that they're interested in and taking their lifestyle into consideration as well. I think that's awesome and brilliant, and seriously is the key in the core to patient-centered care. And then again, targeting interventions with those patients that have those lower activation levels. You can build interventions that are focused on knowledge base, on skill building, on becoming more confident to become a member of the care team, member of that patient-centered care team, rather than the person that healthcare is happening to. Whereas if you go into the higher activation levels, you're moving into more higher level of topics, like a congestive heart failure patient, you're looking at, reducing the sodium, other alternatives. Maybe you're starting to talk about different types of medications aside from Lasix that you can use for longer term benefits. How confident are they? What is their lifestyle looking like? How can they move forward? And how active a role do they want to take in their health? So talk about readmissions, because that's what we're here for. Readmissions, it's considered a failure of the discharge plan. Of course, as a nurse, day 1 of nursing school, very first thing out of my nursing school instructor, my very first nursing school instructor's mouth was not, "Welcome to nursing school. We're so happy to have you here. I'm so excited that you've chosen this caring profession." It was, "Discharge planning begins on day 1. Know it, live it, love it." And I went, "Oh no." We don't even have the patient. We're talking about discharge planning. So when the readmission definition is a failure of the discharge plan, as a nurse, I take that incredibly personally. So reducing readmissions indicates that we've got some pretty effective care delivery things going on, and our transitions are better, and that we've got better post-discharge management. It means that our patients are doing better after they leave us from the hospital setting without having any kind of complications. And it means that we've got better outcomes, we've got better patient satisfaction, and we've got a much better overall quality of care. It also impacts our cost reduction. We all know that we get those horrible penalties, and we get dinged twice for readmissions, and once from not getting paid for that admission event, that readmission event, and second time on the back end with the 1 to 3% readmission penalty based on your Medicare numbers. So, and we also know from many, many years of work, right? We've got tons of factors that contribute to our readmission rates: lack of patient understanding, inadequate care transitions, and non-adherence to treatment plans. If our patients don't understand what it's going to look like for them after they leave the hospital, they're going to be at a higher risk of complication and readmission. If they're not engaged, they're not going to make those follow-up appointments because they just saw a whole bunch of doctors. Why do I have to see another one? Medication errors, taking all those meds first thing in the morning because they don't feel confident that they know how to manage their medication, or they may neglect their self-care routines and not adhere to that diet recommendation, et cetera, et cetera. If we're doing a poor job of coordinating care between inpatient and outpatient care teams, we're talking about major gaps in communication. How many PCPs still round at the hospital and take care of their patients while they're in the hospital? Very few. How many patients are managed by hospitalists? And then we have to tell the PCP, when we're calling to make that appointment with them. Hello? That was weird. So when we're calling to make their follow-up appointment and the doc's like, oh, I didn't know they were in the hospital. Well, okay. Or our patient is trying to make a follow-up appointment because we didn't have the resources to be able to make it for them. And our patient is being told that they don't have an appointment for another, 30 days. And they're trying to tell them, but I was just in the hospital and they have no record of it. We fax things over to their office and who knows where it lands up, right? So those types of faxing a discharge summary over to your PCP's office, that's not an adequate handoff. That is an inadequate handoff. And so we've got confusion, we've got improper management, and all these things can contribute to a readmission. And then again, our patients who don't adhere to their medications, their lifestyle changes that we recommend, or following up are prone to worsening healthcare conditions, which then brings them right back to us to start this all over again, right? Engaged and activated patients are more likely to participate actively in their post-discharge care. They're better equipped to manage their discharge instructions, their medications, to recognize when they need to go back to their provider, and instead of waiting until things get so bad that they need to go to the emergency room, maybe they'll go see their PCP instead and they'll tweak the medication there. They're collaborative, and this leads to a better, smoother care transition, of course, less likelihood of readmission. And they're more receptive to our educational interventions that are going to help them with gain confidence and enhance their health literacy. Because activated patients are better able to apply knowledge to their self-care. They're going to be able to actively manage their conditions. Actively manage, not healthcare happens to me. Active management, active participation. I'm so excited by those concepts. Excuse me. And this is just a little bit of a summary of that last, just for fun and giggles. All right. Biggest thing that we can do for our patients is create positive feedback loops. This is creating that the relationship between the engagement, the activation, and readmission reduction. So our engaged patients are activated, readmission reduction. Readmission reduction leads to activation, leads to more patient engagement. So engaged patients who are more activated are more capable of managing their health after discharge. We just discussed that. More likely to do all the things that we're asking them to do. When patients experience successful post-discharge recovery due to that activation, due to that engagement, they are more likely to become even more engaged in their ongoing healthcare journey, reinforcing their confidence, their motivation. So think about it. If you've got a person whose goal is to lose 100 pounds and they've lost 20, they're psyched. They're like, I can do this. Yes, let's do the next 20. Whereas if you've got a person whose goal is to lose 100 pounds and they haven't done anything about doing that, and they're still, at no weight loss, or maybe they've gained a couple of pounds, they're not going to be so motivated. They're not going to be so activated, and they may just give up on the goal. So it's our job to continue this cycle of feedback and improvement. It's just like a PDSA, plan, do, study, act, plan, do, study, act. Continuing to support the patient and provide them with that positive feedback. When they see results, they want more results, just like everybody else. When we see that we're getting a result, we want to continue to do it more to get more results, right? They're going to become more invested. Yes, We like that. All right. So case study number 1 or 2. We'll put it in the middle. Challenge. The hospital is faced with high readmission rates among our heart failure patients due to poor discharge, self-care, and medication adherence. What's the solution? Well, the hospital implemented a strategy that combined patient engagement, patient activation, and readmission. Some of the strategies they implemented: they educated their heart failure patients about their condition, the treatment plans, and the importance of self-care. Patients were encouraged to ask questions. We were setting personalized goals and active participation in their care decisions. Under patient education, personalized educational materials in print and digital formats explaining heart failure management, medication schedules, and diet recommendations at that patient's specific reading level. Personalized education, meaning meet the patient where they live. You know, can they read? What level can they read at? What language would they prefer it in? Communication, nurses conducted thorough discharge planning discussions, ensuring that the patients understood their medications, the warning signs, the need for follow-up appointments, and go to them. And the results: over a 1-year period of time, readmission rates for heart failure patients dropped by 25%. Patients reported higher satisfaction and better understanding of their conditions and improved adherence to treatment plans. Now, some of the things that we need to think about: let's be practical, because that's my brand now, is the practical guides, right? Incorporate patient engagement strategies during hospital stays, like involving patients in care discussions. Bedside report has got to be one of the best inventions ever, because it involves the patients in that handoff, that handover, and the patient can correct anything that's being misrepresented. All right. And the patient can set the goal for the day too during that bedside report. You know, we're going to be, we got a goal today to reduce your sodium. Well, maybe not that much, but let's just drop it a little bit maybe. And okay, well, we'll see what we could do. Regularly seek your patient's feedback about how clear the instructions are getting and what's your comfort level with, can you use the Coleman-Wasson tool? On a scale of 1 to 10, how confident are you that you're going to be able to do this? Technology, patient portals, education resources, medication reminders, communication with the healthcare providers. If there's one thing that's come from technology, it's instant communication and instant connectability. And so, a patient that feels that they can reach out to their physician in a quick manner and get an answer, within a couple of hours is it can be pretty engaged. All right. Clinic noticed that diabetes patients struggling with self-management, leading to frequent emergency visits and readmissions. The clinic launched a patient activation program to enhance their ability to manage their diabetes effectively. Some strategies: they used the patient activation measure, or the PAM, to identify individual patients' activation levels and tailored the interventions accordingly. Patients with lower activation levels received diabetic education, understanding blood sugar monitoring, medication management, and dietary choices. And as you move up that PAM, the education changed. It wasn't a one-size-fits-all. It was, as you moved up, your education moved up with you. Goal setting. Patients worked with their healthcare providers to set achievable diabetes management goals, which gave them a sense of ownership over their health. And in 6 months, the patients in the program exhibited improved diabetes management, better adherence to medication regimens, and a significant reduction in emergency visits and readmissions. Again, going back to our patients, gather those insights from them about their challenges and use that to design effective patient-centered interventions. And then maybe create an app, or recommend an app after you've done some research out there about which app works best for providing those personalized tips, for helping them track their blood sugar levels, and giving that digital dopamine for meeting goals. All right. Remove my toolbar from the top because it's blocking what I'm trying to look at. All right, practical tips for healthcare providers and organizations. Again, Involve your patients. Involve your patients everywhere you possibly can, because the more you involve them, the more they feel that they are empowered and they have a sense of ownership. Help them set achievable health goals. Take that big health goal and cut it down into bite-sized pieces. I think there's an old saying that says, how do you eat an elephant? One bite at a time, right? Incorporate that patient feedback and preferences through surveys, through focus groups, patient advisory boards. Hey, what are we doing good? What could we do better at? Because you want to know what you're doing good so you don't get rid of that. Don't want to throw the baby out with the bathwater, right? You want to customize care plans on their preferences or lifestyle, their cultural factors, really create a patient-centered experience that engages and activates your patients more. And you want to leverage technology as much as you possibly can, because, but again, to the HIT standard, make sure that your patient or their caregiver are technologically able to manage the technology that you're recommending. Address your cultural barriers, come up with some strategies. Healthcare staff, of course, should undergo training to understand these cultural beliefs, the practices, any kinds of communication styles that they should know about. And I will die on this hill. Use interpreter services or translated materials, not family members, not other members of staff. Use certified medical interpreter services so that your message is being given to the patient the way that you want it to be given to the patient. And the questions coming back from the patient are the patient's words, not the interpretation of somebody else. All right, couple more. Cultural competency. Dr. Lee, a cardiologist at the community hospital, notices a high, hold on, I gotta move this one again. This is annoying. High readmission rate from patients in the local immigrant community. After a thorough review, she identifies cultural differences as a significant barrier to patient engagement. Many immigrants have a limited understanding of the prescribed cardiac rehabilitation due to language barriers and cultural beliefs. Some believe in traditional remedies over prescribed medications, and others are hesitant to engage in follow-up care due to past experiences of cultural insensitivity. So what does Dr. Lee do? She organizes a cultural competence workshop for the healthcare staff, focusing on the specific cultural backgrounds of the patients that are served. Workshops are led by cultural liaisons from the community, providing insights into the patient's beliefs, values, and communication preferences. This also includes role-playing scenarios to help the patients or help the staff practice sensitive communications, and they learn how to adapt care plans to the patient's cultural context without compromising the medical standards of the care plan. And then the hospital also partners with a language service provider to make sure that professional medical interpretation services are available 24/7, especially when we're talking about discharge planning and the discharge instruction process and during follow-up appointments. Again, the educational materials are translated into the languages spoken by the community. They are reviewed by community representatives to make sure that the translations are culturally appropriate and understandable. I love that. In using those insights, the healthcare providers are able to explain health information in a culturally relevant way, which therefore increases patient engagement. Community health workers can be hired to facilitate discussions about health topics in the community. We're seeing community health workers more and more out in the communities, trying to connect and engage with our patients. And then also they have to understand the cultural context to be able to better motivate our patients to take a more active role in their healthcare. And then with that comes improved communication, improved trust. Patients are more likely to follow through. Therefore, we're going to get reduced readmissions. And 6 months into the implementation, the hospital does indeed see a significant decrease in readmissions. Patient satisfaction scores improve because the patients are now being treated culturally sensitively. And the staff are now also reporting feeling more competent and more confident in providing care for this culturally diverse patient population. Health literacy, we went over this quite a bit. Plain language, use visual aids as much as possible, and get involved with creating health literacy initiatives in your facilities. Metro Hospital's spike in readmission rates is linked to a subset of patients with chronic conditions like diabetes and hypertension. Dr. Smith analyzes the data, discovers that many of these patients have low health literacy. They are unable to comprehend their medical condition and the importance of their medication adherence, their diet, and the follow-up appointments. Of course, what does this lead to? Bad outcomes, frequent readmissions. Dr. Smith initiates a back to basics communication training for all healthcare providers using simple, clear language when explaining medical conditions and adopting a policy that all written materials must be vetted for plain language before being distributed to patients. Team creates a series of visual aids, including diagrams about how different medications work and videos demonstrating how to measure blood sugar levels. Exam rooms are equipped with tablets for infographics and short clips to explain common procedures and common post-discharge care. And they partner with local community centers to conduct health literacy workshops covering topics like how to read a prescription label, understanding how to take a medication when it says, take twice a day, when do you take it? Navigating the healthcare system. Hospital establishes a health literacy corner in the lobby where patients can access educational materials, receive assistance from volunteers trained in health literacy. Clinicians use TeachBack, the holy grail of health literacy. And the hospital launches an app that sends daily reminders for medication, weekly tips on managing their conditions. Patients who complete the health literacy workshop are invited to become part of the Patient Advisory Council. And then they become peer educators in the community, trained to support others. I've seen this work with my ESRD patients here in Chicago. One of the case management managers at a large teaching facility created a peer mentor support group for ESRD patients, coupling up a seasoned ESRD dialysis patient with newly diagnosed patients who were just going on to dialysis to kind of support them through the first couple, years of it, because we know adherence rates for newly diagnosed dialysis patients are really horrible. It worked quite well. Each patient is given a personalized health literacy toolkit at discharge, easy to understand instructions, a medication schedule, so people know how to take their meds, and a list of symptoms that, call your doctor. Follow-up phone calls in 48 hours, go back over all that stuff. And within 1 year, Metro Hospital observes a 30% reduction in readmissions with chronic conditions, higher satisfaction with the care, notable improvement in self-reported health management skills for people who participated in the health literacy initiatives. Yay! We all have resource limitations as well. I've got 3 minutes. Yes, I'm going to do it. Time, personnel, funding. Riverside Clinic had the same problem. They needed to do an assessment to figure out where they needed to pour their focus on their resources in. They created streamlined care pathways to prioritize post-discharge follow-up calls, medication reconciliation, and linkage with home health services, making sure that the tasks were delegated appropriately throughout the care team. Using some non-clinical staff for basic routine follow-up phone calls and basic education. Then they would transfer the patient to a nurse if there were more complex needs. Patient education was, patient engagement was really great because they were using a checklist to make sure that everything was covered. The volunteer program with local college students who are interested in healthcare careers was implemented. There's some more resources for you. Then you've got your activation. The community health worker program was initiated. They had monthly CHF education days where people could come in and learn more. And within a year of these strategies, they see a marked decrease in their CHF population. They've got technology on board with increased efficiency, and they are prioritizing high impact interventions for the clinical providers, and the routine, more administrative stuff is going to non-clinical providers as well. And then collaboratives with our community resources, making sure that we are connected. Dr. Morgan put together a Healthy Community Connect program to forge partnerships with local nonprofits, food banks, housing authorities, and transportation services. We all know that 80% of healthcare is related to social determinants of health, so this was a solution for it. They also started a community health worker program as well. and integrated all of that together that combines medical care with social support services. The model was piloted in departments that had a higher readmission rate, like cardiology and endocrinology, with multidisciplinary care teams. And the results were a decrease in readmission rates, especially among our chronic condition patients. Yay. All right. I'll leave this one for you guys to play with your own self. There's a couple more in here. So, future directions. Healthcare landscape is undergoing transformation towards patient-centered care. We've been talking about it for a long time. We, as case managers, are the masters of patient-centered care. So we know this. Why is it so important? Well, we know that it's important for our patients to be involved as active participants instead of healthcare happens to me. And this shift acknowledges that patients are more than just recipients of our medical treatment. They are the center of it. They are partners in their care journey. We have to keep remembering that this is their care journey, not ours. And there you go. So patient activation, patient engagement. Engagement is the strategy. Activation is the individual focus. And that's the outcome that we want. We want highly activated patients to make sure that they take care of themselves, that they're empowered to take care of themselves, that they're equipped to take care of themselves, and that we are here as a resource for them when things get out of control. Ta-da! Any questions?
Thank you very much, Colleen. It was an excellent lecture. Hearing your experiences and all the different strategies and new technologies that can be used to for readmission avoidance. So
during the break, I will find the Simon trailer and I'll play it when I come back.
You get a second chance for another lecture. So there is one question in the chat.
Sure.
And it is what about patients with behavioral health issues that are affecting their higher incidence? In other words, are a frequent flyer in the ED. And then any tips on how to address this post-discharge?
I'll start with any tips on how to address this post-discharge. We've got to stop putting our patients into silos within themselves. A patient's behavioral health impacts their medical health impacts their behavioral health. So often in the hospitals, we see, okay, patients coming in with CHF exacerbation and they have schizophrenia. Okay, get psychiatry on consult, and psychiatry doesn't want to touch the patient until they're medically stable, and then they'll take them up to the psychiatric floor, or they'll come in and they'll work on it. But at the same time, the medical doctors don't feel comfortable managing the patient's psychiatric medications. And this whole splitting the patient into two sections has got to stop, because we know that a patient's behavioral health issues impact their medical, and their medical impacts their behavioral health. So they have to be managed concomitantly, not just in the hospital, but out in the community. So the PCPs also need to understand that this person presents as this entire person, and you can't just treat one side and sacrifice the other because you don't feel comfortable with it. Integrated case management is one of those things that is really going forward with trying to break down that silo within the patient, recognizing that people are holistic, WHO, whole people. So having case managers in the emergency room to identify, and social workers in the emergency room to identify patients coming in that have behavioral health issues, and starting those conversations in the emergency room with the ED doctors, and getting that psychiatric consult on board to co-manage that patient if the medical team doesn't feel comfortable managing the psychiatric medications. Working together to identify, do the psychiatric medications have any impact on the medical diagnoses, and vice versa. Yes, there you go.
Great answer.